Thank you very much.
Thank you for your kind invitation to this very interesting EORTC meeting. And if I understand well, I have been asked to make a general overview, which is not so easy, about the aims of combined modality in rectal cancer. You know my disclosure, I have been using contact therapy and now the papillon machine for more than 40 years, and you will hear from this very specific and efficient technique, of course. I will speak of the aims, which is mainly to have a cost-benefit ratio, that's the aim of every treatment in medicine. I will give some words on what did we learn from the randomized trial in T2, T4, and you will see that finally we must be, I think, quite humble. Then I will rate the present hypothesis and see what we can achieve for the next trial to come. And I will finish by the T1 and 0. So I will speak mainly on T2, T3, T4, M0. Aim of treatment, general philosophy, very simple. We want to cure the patient, and in cancer it is always twofold, local control and distant metastasis. We want to avoid toxicity, and now we are speaking not only of early toxicity, but late toxicity 10 years, 20 years after, and we are right. And secondary radiation-induced cancer sometimes is in the field, but I'm not sure it is very important. Then, of course, now quality of life is important, and in rectal cancer, it is mainly the function of the bowel. And at the end, we want to cure 100% of the patient without any toxicity back to a normal life, and we must have the financial money to do that in our countries, which is not always evident. And when you think of this cost-benefit ratio, at the end, the toxicity will always be the limiting factors. It's why the surgeon cannot remove everything. It's why we cannot give 100 grays. It's why the chemotherapy, you cannot give everything, because you are limited always with the toxicity. And this from Hippocrates, primum non nocere. Now in French, we call it principe de précaution. And most of the trial is because of toxicity and not because of recurrence of the cancer. Surgery is the main treatment, we'll all agree. And when we do this multimodality treatment in association, the only way to have evidence is to speak of randomized trial. I will speak only on randomized trial. Out of randomized trial, you are never on a strong evidence. If you all agree, surgery is the main treatment. And surgery, I think, is the field of research where they have made the most important improvements for the past 10 or 20 years. TME surgery, which is at the same time less toxic because you spare the nerve, and more efficient because you have areolar dissection. Intersphincteric resection to preserve the sphincter, even if sometimes the bowel confidence is not perfect. Laparoscopic surgery, we have heard this morning that from the point of view of general health, capital is better, and for local excision, TEM surgery is good. Don't forget the anesthesiologist and the intensive care, and probably the most important achievement over the past years. When I started, when you operate a cancer, it was 10% operative mortality. Now it is 1%. This is a great achievement. Overview of neoadjuvant treatment. You remember that some years ago in the States, the standard was Postop chemoradiotherapy. And it was thanks to the Germans and Dutch and the Swedish trial that pre-op became the standard. Then the EORTC and FCC trial showed that chemoradiotherapy was more efficient. Then the accord at 50 gray, the STAR and CERN that no concurrent oxaliplatin, and we know that 5x5, even with TME, is a good treatment. And this is probably the most important achievement of this treatment, that on the long term, at 10 years, chemoradiotherapy is really diminishing the rate of local recurrence from 20 to 10%, quite a good achievement. 5x5 or radio chemo. You know this Australian trial, which I think the most interesting one. Despite 1% sterilization and 15 here, no change in anterior resection. Small advantage to chemoradiotherapy here, especially, you know, in the distal rectal, but no difference in overall survival and no difference on local toxicity. We'll speak on that later. Stockholm trial, 5x5 immediate, 5x5 delayed. the surgical toxicity is smaller when you delayed. Survival, of course, it is the role of chemotherapy. You have a lot of trials. Some are positive, the Japanese, the Quasar. Some meta-analyses are positive. The work of Christophe Buschko is negative. Recent result from the URTC is negative. The Proctor and the Script trial in Netherlands is negative. And I understand from my British friend that the Chronicle also is negative. So overall, probably, we did not achieve any improvement of survival with this chemotherapy. We have interesting hypothesis that we can give the chemotherapy first line. What is surprising is that if you look at the guidelines, if you go to the United States, NCCN, you give adjuvant chemotherapy always. If you go to Netherlands, you give it never. If you go to France, it is written, there is no evidence that adjuvant chemotherapy is useful, but you can give it when you want. And I agree with Christophe Buschko, made a nice talk one day about guidelines, and the conclusions was, don't follow guidelines. Then toxicity. Did we improve about toxicity? Early, toxic death from cardiovascular disease with chemotherapy, post-op, and you will see that radiotherapy is playing an important role, and of course, late toxicity, bowel dysfunction, secondary induced cancer. This was one of the first URTC trials I participated, 1984. Look at the fields. Huge fields with chemoradiotherapy, 1.5% deaths during treatment, 9% deaths post-op due to the radiotherapy. You may remember that 4-gray whole-body irradiation killed 50% of the population. Then the Swedish, they irradiate 5 by 5 until L4 level. Post-op deaths, 14%. The key of success is small field. And the main reason is that most of the recurrences, even not all the recurrences, are below S2. That's been very well demonstrated by our Dutch colleague. And we have evidence that small field is working, but we forget the past. That's a very interesting trial. People came to see Papillon was using a 10 by 10 field, and they reproduced it 10 by 10 fields. And they randomized 284 patients, 10 by 10, not a big dose, 20 gray, not 25 gray. Surgery alone, 36% local relapse at that time. It was not TME surgery. Only 12% with a 10 by 10. And out of the 16 recurrence, 10 were within the small radiotherapy field. This is the key of success. If you want to be friends with the surgeon, don't harm the surgeon, do for small field. Never irradiate the anal canal, never irradiate above S2, never irradiate the small bowel, and you will be on the safe side. And with such recommendation, the Accord 12 trial, we had 4% local relapse, less than 2% grade 3-4 toxicity at 3 years. Very interesting work on the toxicity from the CRO7, conclusion, large randomized trial, validated questionnaire, main adverse effect in men is sexual dysfunction, which is mainly caused by surgery. Pre-op radiotherapy can affect sexual and some aspect of bowel functioning. This is true. It is very small if you don't irradiate the small bowel and the anus. And to my surprise, when you look at the De Vita textbook in 211, this is the field, 2.6 liters. This is the standard. Toxicity and age is important. Above 70 years of age, in this Accord 12 trial, there was more interruption of the treatment, less surgery, more stoma, more post-op deaths. And it was well demonstrated by Hans Strutten that even with TME surgery, when you are elderly patient, you have a lot of patients dying after surgery, more leakage incontinence, and he said less invasive surgery and more contact therapy. Thank you, Hans, for these nice words. So what we have achieved so far? Aim of treatment. Local control, yes, but problem mainly due to good surgery. Survival, no problem. Toxicity, yes. Post-op death, be careful in elderly. And thank you for the anesthesiologists for the good intensive care. Now I come to the most important part, conservative treatment. To know if the neoadjuvant treatment has increased the chance of sphincter preservation, the only way to answer this question is to go to the randomized trial. And Christophe Bouchko and myself, we have made this work. And it is common sense to think that when you shrink the tumor with a preoperative treatment, you increase the chance of sphincter preservation. And it is not true. If you look at the results, forest plot, all the trials, sphincter saving, no difference, except a small trial I will go on later on. Another demonstration, the Korean people, they reproduce the German trial, pre-op versus post-op. In post-op, 0% sterilization, of course. In pre-op, 21%. No difference in sphincter preservation, no difference in toxicity. And they use a very good regimen, the CAP 50, which is the French standard treatment at the moment. Why is this? Why we don't increase sphincter preservation? It is because, it is not new, adenocarcinoma of the rectum is a radioresistant tumor. And this is the hypothesis made some years ago. This is a tumor that most of the surgeons will treat with APR. If you do radiochemotherapy, you get a partial response with this finger, intelligent finger, educated finger, the bioprobe of the Swedish people. He sees the tumor, he says, I do the APR, and he's right. The only way for the surgeon to change his strategy is that he sees nothing, he feels nothing, you have a clinical complete response. And the clinical complete response was demonstrated with papillon technique, with a contact therapy technique, and was popularized by Angelita Bergaba, and she's right. This is the key of everything if you want to do conservative treatment. You must achieve clinical complete response, and you must have a strict definition to follow by watch and wait, or maybe, if you like it, local excision. And what is the best way to define a clinical complete response? Of course, we have Gina Brown, and you do the MRI, and it is quite good. But if you add the rectoscopy, it is better. And if you have the digital examination, it is better. The most reliable way to assess the clinical complete response is good clinical examination by an experienced clinician. This is the key of everything. You should buy these things. 4 euros, disposable rectoscope. You see the tumor in the chest, you put your finger, it becomes intelligent when you have seen the tumor, and you assess the clinical complete response. And it is true that the adenocarcinoma is radioresistant. It has been nicely proven by the Danish people. They made a trial where they increased the dose in the rectum by iridium implant. And then they had some results, and they find that the dose which is able to sterilize 50%, not 90%, 50% of T3 is 92 grays. This is radioresistant. The interval can increase the sterilization rate. We showed it in this trial in Lyon, short interval 7%, 14%, but does not translate too much into sphincter preservation increase. But no detrimental effect at 15 years. But at 15 years, we have already 12% of secondary cancer. There is obviously a radiation dose escalation limit. It was nicely proven in Toronto, 40 gray, 45, and you see the increase in sterilization. Clear dose effect is evident, but it will be impossible with external beam radiotherapy only due to the toxicity and the tolerance of the pelvic structure to achieve more than 70, maybe 80%, 80 gray to the tumor. So the only way to go to 90 gray is to use endocavitary safe dose escalation. You can do it with iridium HDR. This was a randomized trial, which unfortunately increased the response, but not the rate of anterior resection. And if you don't succeed with the iridium endocavitary, you can use the contact therapy. And it is said there is no proof that it is working. Well, it is not true. You know that it is a unique technique, high precision, high guided. It is like the TEM. Instead of taking the tumor out, you irradiate it with your vision accurately. And there is a randomized trial to prove it is true that the clinical complete response has a clear impact on the conservative treatment. It was done in Lyon some years ago, T2, small T3, low distal rectal tumor, external beam pre-op, external beam, plus 3 courses, 90 gray of contact therapy. Endpoint was sphincter preservation. And we wanted to move from 40 to 70%. And the result was positive. Operable patient, external beam alone, clinical complete response only 2% because it is radioresistant. But if you give 90 gray in 3 fractions, you move to 29%, nearly 30% difference. And this translates in 30% increase in sphincter-saving treatment. And this was not foreseen. To my surprise, it increased organ preservation. Out of these 45 patients, 10 of them, either with the Angelita watch and wait or with local excision, were able to preserve their whole rectum with a perfect bowel function. And we have updated this result at 10 years, and everything is published. And at 10 years, there is still a 30% improvement in sphincter preservation when you give the contact boost because you get the clinical complete response and the surgeon reappraises his decision and make a conservative treatment. And there is no detrimental effect by this treatment on local recurrence and survival. All of you have seen this patient, a lady patient. The tumor is here with my rectoscope, rigid rectoscope. I can get a picture. This is the anal canal. It is a T2, very low. The surgeon said, give radiotherapy, I will do APR. She was randomized with a contact, and she had a clinical complete response. And this clever surgeon said, I will change. And he made a local excision. You have the anal canal here, the ulceration, residual, everything is sterilized, mucoid flak in the muscularis propria. It was really a T2 tumor. And now, with this more than 12 years, this patient, normal life. Conclusion of this randomized trial, if you increase safely the dose, you increase TCR, more sphincter saving, and most of all, organ preservation, and no lymph node failure. Now, it is not no anymore a hypothesis, it is a paradigm, well demonstrated by Angelita. When you achieve clinical complete response, you may try to achieve organ preservation. And to my pleasure, contact therapy is not anymore in France. It is in Liverpool Clatterbridge with Professor Sunmint, who has opened a papillon clinic. He's doing 150 cases a year of papillon technique in this clinic. You can see the results. And 312 patients with T2, T3, our actual group, 72% local control, and no isolated lymph node relapse because we do the external beam radiotherapy and the chemo. These are the tumors you should see with your rectoscope. This is in Nice. This is in São Paulo. This is in Liverpool. This is in Maastricht. These are T2, early T3. When you irradiate them properly, you have a clinical complete response. You can make organ preservation. So what we have learned? Well, quite modest. I said, local control, mainly the surgeon. Survival, no difference. Toxicity, yes. Post-op death. And no treatment except if you do endocavitary. So what are we going to do now? What is the aims of our treatment? As always, local treatment, survival, reduce toxicity, improve sustainable cost for society. If you look to all the PDQ trials, what you see, some of them try local control. In France, we have for the T3, T4, where in the Accord 12 trial, we still have 9% local relapse. We want to do chemotherapy first, good, poor response, 50 gray, 60 gray. We want to improve the R0 resection rate, local control. The surgeons are playing a major role. You have understood. You have a nice talk on the T4 with the extra levator surgery and the nice surgery. This is key point. Robotic surgery, quite expensive, but maybe worthwhile.
You have less than a minute.
Okay. Treatments, distant metastasis survival. Well, the Rapido trial, why not try to give a lot of chemotherapy with 5x5 and increase this? In France, we do the same thing with FOLFIRINOX. Of course, we want to do the biotarget drugs. You know it is complex and heterogeneous. When we look for biomarkers, well, a lot of them, we are afraid of resistance, and it's quite a lot of money to find the drug for that. So keep fighting for this. Toxicity, we will reduce the toxicity in the elderly patient instead of 40 K50, 5 by 5, reduce the toxicity, and we will heard of chemotherapy alone. Proton therapy, with proton therapy, this is a new machine will arrive in 3 weeks. You irradiate only the tumor, no more bowel problem, no bone marrow toxicity. You can give the full dose of chemotherapy, and this is very good. And there is a lot of machine now. I will skip the scan. Quality of life, chemoradiotherapy for organ preservation. This is written by a surgeon. And in Lisbon, they made a trial with all the surgeons when not to operate. And this is the key of this question. We will do the OPERA trial to demonstrate that for this tumor, T2, T3, operable, low and middle third, if we give external beam boost versus a boost with contact therapy, we'll assess clinical response. If clinical response, watch and wait, or maybe local excision, and we want to move from 5% to 25% of sphincter preservation. This is the patient I have seen last week. This patient, if you have contact therapy, external beam chemotherapy, you have 90%, 95% to a clinical complete response. This patient will have local excision. I will skip the T1 and 0 to go to the conclusion. And the conclusion is, you have to ask the patient what we can do for aim of treatment. We can improve local control, not so much, it's not so far too bad. We can improve survival, we must find a good treatment. Toxicity, reduce the volume of radiotherapy. Speak with your radiation oncologist. Ask why is he radiating the anal canal. Ask why is he radiating to the promontorium. There is no need for that, and you give toxicity. And maybe the best improvement we can do is organ preservation, achieving clinical complete response with some endocavitary radiotherapy, cost-benefit ratio, financial cost, randomized trial, and don't forget that to achieve this, we must go back to the clinic, speak to our patient, do the digital examination, and do the rectoscopy. Thank you.
Thanks very much. May I call the next speaker, Dirk Arnold?